Let's welcome them to the stage, Senator Gene Davis and Representative Jim Dunnigan. Representative, I'll start with you because you were literally one of the first people I met with, and you said yes, and if you had said no, we probably wouldn't be here today, so thank you for doing that. Give me a recap first. I heard, I think in the Republican panel, I think it was said that there were about 850 bills introduced this year, drafted and introduced. About 242 of them were healthcare bills, and about 152 or 154 of those healthcare bills were passed. There are some headlines about healthcare. It was a busy healthcare session, but maybe talk about some of the non-SB 96 bills that passed. We're going to talk about that in a second, but what else was going on? Recap the legislative session.
Yeah, okay, that's like somebody asking me to talk about Medicaid expansion in 5 minutes. So
we're going to get to that one. You get 30 seconds for that.
So there were several regarding professional licensing and scope of practice and trying to expand the scope of our medical and behavioral health providers so they can treat more people and help meet the demand. There's many things from telehealth to addressing the opioid issue, and so it's very broad. We had a discussion on balanced billing, which we did not resolve this session, but so that's still lingering out there.
Yeah. How would you put this session in context compared to some of your other sessions? How did this one compare for the amount of healthcare legislation that moved through?
Well, the first 2 weeks of my session was spent on Medicaid expansion. That's not what I had planned. I actually had things I wanted to do this past session, but it was almost 24/7. We had the Proposition 3 and that passed, and implementation date was April 1. We'd had some recent conversations with the federal government, kind of encouraging us to do some things. And so it was, very healthcare oriented, at least for me. And then the very end of the session was very tax reform oriented, two heavy lift bookends.
Yeah. Senator Davis, same question. I think we discussed you got elected for the first time in 1986. Some of you were born about that time. How would you put this session in context, or how does this compare to other legislative sessions that you've participated in?
This session was an interesting session. As Representative Dunnigan had indicated, we ended up in the first 2 weeks really debating Proposition 3 and changing that with Senate Bill 96, the Medicaid expansion. That took a lot of time. And then, to the end, the tax issue. In between, it was pretty quiet, pretty comfortable, pretty direct. It was really a smooth session in so many ways as we came out. We had probably more bills than we've ever had before introduced. We actually passed about the same amount, just a few more than that. But it was very deliberate. It was a deliberate session, I think, more than some of those that I've seen with controversy. Part of that is because we had more money than we'd had in the past. It really gets really challenging when we have a downturn in the economy. And so when we take a look at healthcare reform in the state of Utah, what comes to my mind is the fact that we really do need the federal government's assistance in this to be able to maintain healthcare at a level that we can do in the state of Utah. Because a downturn, and we have to cut budgets.
Let me ask you, Senator, I've heard a number of legislators say over the years, forget what you think. The enemy, if you're a Democrat, as you are, the enemy is not the Republican Party. If you're a senator, the enemy is the House. And that the Republicans and Democrats get along pretty well in one chamber, and the real enemy is the other chamber. Is that accurate in your experience? Talk to us about the sort of partisan and chamber divisions.
The tension between the chambers is very, very real. I take a look in Utah, where we have 75 representatives and 29 senators. The contentions that go on in the House are far greater because you have 75 people. And I believe that everybody that's elected to the legislature is elected as a leader. And I think we all have ways that we would govern, the ways that we would say that this is the way it is. And it's convincing our colleagues that that's what we need to do. It's my way, and you have to adopt the fact, but it's not necessarily the highway. And so there's a lot of coming together. I believe when you take a look at the majority caucus, they come together. The minority caucus comes together with their ideas, and they're worked out, and there's compromise in both bodies that way. Then the challenge becomes 29 versus 75, who may have the same idea, but not the same conclusion.
Representative, similar question. I think people who don't get the joy, the burden and the glory, so to speak, the joy and the pain of being a legislator during a legislative session may not always know these sort of nuances. Do you maybe explain how well the House Republican caucus works with the House Democratic caucus, and what the tension is like maybe instead of between parties, maybe between the two chambers? Same kind of question. Put your spin on it.
Well, I'm a Republican, and we love our Democrat caucus and colleagues in the House. And we are not like Washington. If there's anything I can convey, we are not like Washington, where they're constantly at each other. They rarely do anything, and when they do, it's probably not good. So we get things done in the Capitol. We have a balanced budget. We put money away in the rainy day fund. And I think we do a good job managing our state. But if a Democrat in the House has a good idea, I will support it. And I hope that they will reciprocate. And it extends to the Senate. We have our challenges with the Senate, and we have to bring them along from time to time. But we for the most part, we work together. It's, I would say, rarely about personality. It's generally about policy, and that's what I believe it should be about.
Mm-hmm. Let me ask sort of a basic political philosophy, Representative Dunnigan. If we set aside natural law and we set aside religion for a second, do you believe that the ultimate political power comes from the people? And let me parenthetically add, this is really a question about the role of Prop 3 and SB 96. Is the highest power in a political entity or in the Utah Constitution, in your view, the people, or is it kind of a blend of power between the legislature and the people? What are your sort of political, philosophical thoughts on that tension?
I serve at the pleasure of my constituents. And so for me, ultimately, the power comes from them. They elect me to represent them. I run every 2 years, and the Senate's every 4 years. But we're constantly answering to the people. And so my voters are the ones that I report to. My challenge is they don't all agree with each other. You know, I come from a swing district, and so I can make about 50% mad and 50% okay with me about everything I do. And so it's trying to find that balance of good policy.
Yeah. Senator, same kind of question. Obviously, it relates to the marijuana proposition. It relates to the Medicaid expansion proposition. Explain for us, I asked you this question recently, last night, and you had an interesting sort of take on it about the Utah Constitution. What has primacy when it comes to political authority, the people or the legislature, in your view of the Utah Constitution?
In the long run, it's the legislature that has the ultimate power. However, because we're a representative form of government, which takes the people to elect us to represent them in the form of government that we have. I think when I take a look at the propositions that were passed this year by the people, did we rush to judgment? I believe we did on one. I believe we didn't on the other. When it comes to the Proposition 2, which was the medical marijuana bill, the people prevailed on that. It passed. I voted actually with the majority. I was the only Democrat to vote for the compromise bill. And the reason I did is because it became aware to me that the people voted for medical marijuana, not recreational marijuana. And there are so many pieces inside that proposition that gave recreational marijuana more people the ability to grow their own. And the one thing I heard from doctors and other professionals was the fact, what is a dose? How do I regulate this? How do I know I'm giving the right prescription? And so the compromise came down to the point that addressed those issues for medical marijuana, and I think that was the important part. on Proposition 1, and I may be taking too much time, but Proposition 2, or 3, excuse me, the full Medicaid expansion, I carried the full Medicaid expansion bill in the Utah legislature for 4 years prior to it going on the ballot. I believe in the full Medicaid expansion. People should have ability to have access to quality health care at an affordable rate. And with the 90-10 match, I believe that was the right way to go. And I still believe that is the right way to go. And I think it's cost effective to do that, to deliver full Medicaid expansion to everyone. So I fought against what was proposed. I think there was a part of the budget in the 4 years that I carried that bill was never to exceed, or it was expected to be at $50 million by 2024. That's what the cost of the Medicaid expansion program would be. That was consistent from our fiscal analyst for 4 years. The change in the bill 96 was the fact that there was this, we can't afford $150, $160 million and a growing cost in doing that. And I disagree with that. I think our fiscal analyst was right. They still stand by those numbers, that it was not that expensive to do. The people actually raised their own sales tax to be able to pay for the Medicaid expansion. And I believe that was the right thing to do.
So Representative Dunnigan, walk us through maybe an insider's account of Senate Bill 96, because it got a lot of coverage, and there was a lot of political activism on a number of sides there. But kind of take us behind the scenes a little bit. How did that kind of come together following the November election up through the final compromise? What can you share about that process?
Well, as we all know, Proposition 3 passed, and with an implementation date of April of this year. And the governor's office came out with their financial analysis that in 2 years it would start to go in the red, and then it would just get worse and worse and worse. And I have, speaking of our nonpartisan fiscal analyst, I have their report that shows by 2024, even with the $106 million that they think will be taken in from the sales tax to help fund it, it'll be $65 million in the red just that year. So this is a generational decision for Utah. We want this to be sustainable, and we want to be able to afford it. There's many other states that you can look at to see that they've expanded, and now it's causing cost overruns. And so one of our responsibilities, our state constitution says we have to balance our budget. And so we do that. Okay, we'll expand Medicaid, but we want to do it in a fiscally responsible way. So that's what Senate Bill 96 did. It is, let's provide coverage for everyone in the coverage gap, every single person in the coverage gap. We'll ask the federal government to pay 90% of the cost instead of our traditional 70% match. And we'll take out the escalator. In Prop 3, there was a guaranteed pay raise for the providers. And that blows up. That blew up the budget. That blows it up. In 2024, that alone is going to cost $56 million. Not only because it gave a guaranteed pay raise to all the drug companies and the hospitals that treat the expansion population of Medicaid, but also the couple 100,000 people have traditional Medicaid. They put into law that they get a pay raise every year. And I might add, that's not at the 90-10 match. For our traditional Medicaid, that cost of living increase would be at 70-30. So that blows it up. We met with several of the proponents early on in the session for Prop 3, and we said, this guaranteed escalator, this guaranteed pay raise, doesn't make it fiscally sustainable. And they said, we see that. We would like you to do a technical cleanup and take that out. And we said, we don't know that that's really a technical cleanup. You know, you're taking out 30, 50. But the net result of that is, of the $100 or so million that the sales tax increase was going to generate to pay for Medicaid expansion, 30% of that was just going to provide these pay raises for providers, and that's not sustainable. So we tried to find a sustainable path. We got a working group of a variety of stakeholders together, including some of the strong proponents. And we marched through the path, and it went through the Senate in one iteration, and then it came to the House, and we improved it.
Mm-hmm. So one of the things we heard this morning from the former governor of Oregon, John Kitzhaber, who's here, is that in the traditional political payoff representative or trade-off, it's sort of costs and benefits, and you're sort of moving. He might suggest you're moving, maybe blame or the cost from one side to another, maybe cost shift to the commercial market. But that whatever you do, you have to address the total cost of care and reform the delivery system, regardless of one's politics. He would argue. There is a discussion about a block grant and further reforming Medicaid in Utah. What are some of the principles you would be interested in seeing as a senior legislator? What are some of the principles you'd like to see in future Medicaid reform efforts, particularly if it's in a block grant model?
Well, I'm not excited about the block grant model unless it's something like the per capita, where as Medicaid grows, because it's counter-cyclical, when the economy goes down, Medicaid enrollment goes up, but our tax revenue's down. So that's a bad time to have a kind of a set block grant. The per capita cap concept is, as enrollment in Medicaid increases, you get that $5,500 or whatever it is per Medicaid enrollee. If you increase 50,000 more enrollees, you get that times the 5,500. It's the escalator. So our state has elected, because CMS is talking about offering to the states just more of a vanilla block grant or of a per capita cap, which somebody's called an individual block grant, in that you get the additional money for every new enrollee, but we have an incentive to try to help the federal government control the inflation on that.
Mm-hmm. So, Senator Davis, I don't believe you're here this morning when former governor of Oregon, John Kitzhaber, talked about this, but that Oregon model is something like an individual block grant where enrollment for new categorically eligible people can continue, but that there's a fixed trend of a per person cost trend. Do you think that kind of individual block grant model would be palatable to advocates and to your caucus or not?
I take a look at block grants, and our biggest problem with the Fed, if there is, on block grants, they have never been maintained. You can take a look at our community development block grant monies, which were one of the major beginnings. There's a lot of block grant money that was given to the state to implement the Affordable Care Act. Those block grants are gone. They dissipated, they went out of, they were time sensitive. In other words, they were there for 5 years and then they were gone. And so when I take a look at the federal government offering block grants, it might be a good idea, but I don't know of any block grant money that has been sustained over a long period of time and actually grown from the federal budget over time.
One thing I think they see in Oregon and other states is if you fix trend and you have a fixed per capita cost, but still allow for categorical enrollment, categorically eligible enrollment, that might be fine. But if you don't also fix the internal inputs of costs like hospital spend, specialty pharmacy spend, you're going to blow up the system. And in fact, some of those entities will gobble up money, leaving less for mental health, less for substance abuse, less for primary care. Is that the kind of thing that you think could get fleshed out in a Utah-specific approach where the top line trend is fixed, but also there's some regulatory action on the inputs?
I think we have to look at that, the inputs, if you will, and what the cost trends are there, what's driving that cost. The one thing I look at, do we need a system change, or is it all, and this is what I hear continually coming from the system, if you will, the healthcare system. We have to change people's behavior. It's all the people. We have to change the people. We can't change people's DNA and what their health care is going to look like in the future. We all have different health problems. We all come from a different geodome type setup, RNA, DNA, all of that, our genetics, and the way that's set up. Changing behaviors can work to a degree, but the changer of behavior, I take a look at hospitals are designed to make money, to make profit. Even the not-for-profits are designed to make money. and to be fair. Insurance companies are designed to make money. There's nothing wrong with that free market society or that driving pattern. Or we can look at the pharmaceutical industry the exact same way. We see growing trend in prices and really astronomical prices on some of the pharmaceutical products. We need to take a look at the economies inside those of our system and fix that and try to make sure without stepping too hard on the free market system, because the free market system in many, many ways is a good way in our delivery pattern.
So Representative Dunnigan, your day job, when you're not spending 45 days in the session, is as an insurance broker. You spend a lot of time in the commercial line of business, and obviously you spend time as a policymaker thinking about Medicaid policy and the Medicaid line of business. It's a little complicated, but follow me. Do you think that your experience in the commercial world, let me ask it this way. If Utah has a successful Medicaid reform package, maybe through some model of block grant, some waiver, should that successful model then be extended in some ways to the commercial space? Or do you think that actually, if we made Medicaid more like the commercial space, if we could learn from that commercial space, it would be better for Medicaid? Or do you think just keep them separate forever?
I think they inform each other, and we've migrated towards each other. We have our accountable care organizations that are, at least most of them, run by an insurance plan, and we're trying to bring in some of that on either, whether it's a commercial or the government-sponsored plan. We've got to figure out a way to manage the cost. You know, from day one, the Affordable Care Act was touted, we're going to help control the cost, you're going to have more affordable health care, more affordable insurance. That's not happened, not to put blame anywhere for a variety of reasons, but it's a challenge to control costs. And in the commercial plans, they've got things that they're doing to try to incentivize behavior, to change behavior. I think we can change behavior. You can motivate consumers to some degree to be better shoppers, to be better educated, to find out that this facility can do the same procedure with good outcomes at a much lower price. And so I think they inform each other. I don't know if there's a magic bullet on either side. Just to be clear, we're not proposing a block grant for Utah. We're not. It's probably more similar to what you said with the Oregon model. It's more like an individual per capita, which gives us, I think, more flexibility. So I think there are some providers in this room, in the Medicaid space, that do a terrific job of managing their dollars and providing good outcome for health care, and the commercial payers do the same space. So I think we can learn from each other.
Yeah, good. As we wrap up, and as the interim task forces get their feet underneath them and get committee assignments, so to speak, what should we expect from the task force that I expect you will continue to chair in the interim?
I will chair. Senator Davis is on the task force. Some issues we're going to look at is on opioids. We're looking at a reduction of the opioids, you know, in the community and society. What about those that have chronic pain and actually need it for not just acute pain, but for chronic? And now they're being restricted. Another thing we're going to look at is for those that are on SSDI, as their income goes up, they immediately start to lose their health care and their benefits. Should there be some phase out? We're going to look at pharmaceuticals again. We're going to look at balanced billing. We have a full agenda for this interim.
Good. And Senator Davis, what are a couple of things that you want to make sure are on that agenda, or if you could, you know?
I think the one thing looking at the agenda going forward, I think I agree with what the chairs are laying out. Also, I think we're going to do a study on cost. I think we're going to be working with a group from Johns Hopkins to look at cost and pricing and everything else. They're doing a national study, and we've been asked to be part of that tie-in. And so I'm hoping that we can get some. We began that discussion of balance billing and cost and the cost of health care across providers. That's the other thing I think we need to look at is as we look at the panels and how do we avoid the panels that are becoming very, very strict. This doctor's in this group of insurance, and you cannot use this doctor unless you go to this insurance company. And so I think we need to look at that as well. That's an issue that I hear from constituents.
Well, Senator and Representative, I just want to say, on behalf of this community gathered here, thank you very much. You guys, we're really honored by your engagement. There aren't a lot of folks who would just come up on stage, let the cameras roll, and let unscripted questions fly. So thank you both for your public service and for being here today. Let's give them a round of applause.